sample size calculation, model intervention.
A very good afternoon, ma'am.
Good afternoon, madam. Punam, madam. Good afternoon.
Dr. Sushma, are you there?
Yes,
Madam, good
ma'am.
afternoon. Hello. Punam, madam. Good afternoon.
Dr. Sushma?
Yes, ma'am, it is audible. Ma'am, shall we start with the... Ma'am, am I audible? Hello, ma'am.
Hello. Punam, madam. Hello. Sushma,
Yes, sir.
am I audible?
Yes, sir, you're audible.
You just check it with Punam, madam.
Yes, sir.
Okay, you just call her and ask her to join again. I think there is a audio problem.
Okay, sir. Hello, ma'am. Hello, ma'am.
Hello. Dr. Sushma. Is there
yes,
a
ma'am.
time to start the session?
No, ma'am. I just want to know, am I audible? Am I clear?
Okay. Now? Okay.
Hello, ma'am. Can I start with this section? Ma'am, am I audible?
Hello, Dr. Sushma, are you there?
Yes, ma'am. I'm
Hello.
there. Am I audible?
Hello,
Yes, ma'am.
Dr. Sushma.
Ma'am, I am there. Am I audible?
Whether I am audible or not?
You are audible, ma'am.
ಏನು ಮಾಡಲ್
Hello. Hello.
Hello, ma'am.
Hey, it's audible. Sushma, you can proceed.
Ma'am, I think I'm not audible to Punam, ma'am.
Punam ma'am, is it audible? Hello. Punam ma'am. Hello. Hello. Wait for a few seconds. Sushma.
Okay, ma'am.
Hello, Dr. Sushma ma'am.
Yes, ma'am. Am I audible to
Yes.
you?
Yes, absolutely. Now, okay.
Okay, ma'am. Okay, ma'am.
I
Now we
think,
can
I think there
proceed,
is
ma'am.
some technical glitch. Yeah, sure.
Okay, ma'am. Om Shri Gurubhyo Namaha. A very good afternoon to one and all. It gives me immense pleasure to welcome you all to today's academic webinar. I am Dr. Sushma, final year postgraduate scholar from the Department of Panchakarma, Karnataka Government Ayurvedic Medical College and Hospital, Bellary. On the behalf of the Department of Panchakarma, I extend a warm and heartfelt welcome to our respected principal, Dr. Janki Vyas ma'am, our respected head of department, Dr. Santosh Ledhari sir, our esteemed faculty members, postgraduate scholars, undergraduate students, and all the participants who have joined us today. Today's webinar is on the highly significant and clinically relevant topic, critical insights of Virechana and classical parameters for assessment, Shuddhi assessment, and need for standardization. It is now my pride, privilege, and distinct honor to introduce today's Professor Dr. Punam ma'am. Ma'am has completed her BMS, MD in Panchakarma, and PhD in Panchakarma. She has also completed medical health profession education, the Mayo instructor course in stimulation and experiential learning, and the certificate course in Kerala Panchakarma. She is currently serving as the professor, head of the Department of Panchakarma, and PhD supervisor at Mahatma Gandhi Ayurveda Medical College and Hospital and Research Center, Salod, Datta Megi Institute of Higher Education and Research, Wardha, Maharashtra, India. Ma'am has 14 years of teaching experience and 16 years of research experience. She has received 40 prestigious awards, including the Best Teacher National Award in Panchakarma and the Young Achiever Award in 2024. Her academic achievements include 7 published books, more than 150 research articles, and 112 conference presentations, and 31 completed research projects in university and international level, 1 granted patent, and the development of Prakriti Virechana software. We are truly privileged to have such a distinguished academician, researcher, and mentor with us today. Ma'am, your presence today is a matter of great honor and privilege for all of us. We sincerely thank you for accepting our invitation despite your busy schedule. We eagerly look forward to learning from your invaluable knowledge and extensive clinical experience. On behalf of the Department of Panchakarma, Karnataka Government Ayurvedic Medical College and Hospital, Bellary, I extend our heartfelt welcome and respectful invite Dr. Punam Savarkar ma'am to kindly deliver her enlightening lecture on critical insights of Virechana and classical parameters for Shuddhi assessment, need for standardization. Before we begin, I kindly request all participants to keep their microphones muted throughout the session. Participants are requested to post their queries in the chat box, which will be addressed at the end of the session. With these words, I now request our esteemed speaker, Dr. Punam Savarkar ma'am, to kindly commence this session. Over to you, ma'am.
Yeah. Thank you, Dr. Sushma, for a nice introduction. And first of all, I want to congratulate to all organizing team for organizing such a nice webinar for the postgraduate scholar. And really, the top selected is having the clinical importance. I want also credit for giving me a
Ma'am, your voice is breaking, ma'am.
senior faculty dais. Now I want the topic which is allotted by the organizer. Really, as I said earlier, really having the so we are generally utilizing or prescribed apart from Vamana, Virechana is quite familiar for the patient. So I think, and it is really very practicable and approachable for the patient also. So I really appreciate for the topic selection for the organizer. Dr. Sushma, please let me know whether my slides are changing or not. So after that, I will start my presentation. Slides are changing, moving?
Yes, ma'am.
Okay. Thank you. So very good afternoon. These are the contents of my presentation which are aligned to the specific theme which is prescribed to me. We will first we will go through the classical foundation, classification, what are the different Shuddhi assessment aspect, and we have go through the critical insight of each and everything. Is there any interruption, Dr. Sushma?
Yes, ma'am.
Is there any technical glitch? My voice is audible, na?
No. No, ma'am. It is clearly audible.
Okay. Thank you. And we will go through the some importance aspect of the Samyak Shuddhi. What are the certain challenges and why there is need of to do the standardization for the same? What are the research evidences which are justifying or depicting the importance of Samyak Shuddhi and in what concern? So, and what are then the key message? All are related. These are the learning objective. I think at the end of this session, the all postgraduate students may be able to the critically analyze and evaluate, identify certain controversies, challenges, and correlate. Basically, my aim is that they should be able to correlate the classical concept with is the modern scientific evidence and the research findings. So those may be helpful for their practice. As Virechanakarma, we are already aware what is the definition, classical definition. That is Virechana, that is the therapeutic procedure, body purificatory procedure in which the elimination of the vitiated doshas, morbid doshas get carried out through the adhomarga, that is the anal region. It is not just merely the only bowel evacuation. Okay, so that's why Virechana is unique, apart from just only laxation. Okay, as the our classical sculpture which depicts that it is the prime therapy of pitta dosha, definitely, and generally in a pitta and rakta predominant disorder, this Virechana is generally prescribed. But when we will see the uniqueness of the Virechana therapy apart from the other Panchakarma, what happened comparative to Vamana, what happened, the Virechana is more familiar and little bit stressful because the compliance rate of the patient towards acquiring this or undergoing this Virechana is quite more rather than the Vamana therapy. And again, the specificity of the Virechana is there is the multiple type of clinical conditions we can definitely prescribe this Virechana treatment. And most important thing, it is the most frequently practiced Panchakarma, not just only the part of the seasonal purification, but at the same time, it is routinely prescribed for the patients also. So according to the Charak, you are already aware that is Virechana. What is the clinical utility? What is the classical scope of Virechana? Yes, when we will go through the Charak Sahita, Sushruta Sahita, Ashtang Hruday, there are the certain indications are already given by the Acharya. There are certain physiological indications. At the same time, there are the pathological indications also. But when we want to do some critical analysis, it is observed that the Charaka, the Charak opinion or the indications which are depicted by the Acharya Charaka are completely the dosha based. They just the predominance disorder. Maybe it may be associated with some kapha also. But Vagbata elaborates the clinical application spectrum of the Virechana because they have taken into consideration about the clinical aspect more rather than Acharya Charak. Sushruta expand this indication to specifically the NCD, which are very common in nowadays. Because when we go through the Sushruta's indications of the Virechana, mainly we can notice that Prameha, Grahani, Rudrog, Bhagandar, Vatarakta. These are quite common condition nowadays. So these are included in additionally included by the Acharya Sushruta in the indications of the Virechana. So we can see that, and again, and moreover, that is Acharya Sushruta have added one thing, that is they have added some clinical assessments also. Clinical assessment also, that is Kafanta, Laghav, and they have more give emphasizes bowel evacuation, but Virechana work beyond that pitta conditions, because roughly, when we will concise all the indications of the Virechana, it can be identified that Mrudu Virechana is reflected there also. So I think so it is a broad spectrum utility of Virechana in all type of doshas, that is Vata, Pitta, Kapha. And Acharya Shanandar specify that when there is a condition of Bahupitta Alpa Shleshma, this is the ideal condition for planning or prescribing the Virechana. I think when we will go through all indications of Acharya Charak, Sushruta and Vagbhat, by prescribing Virechana, what we have to achieve? We have to achieve certain therapeutic goals which are based on the dosha nirharana, as I said earlier, which I have mentioned on my introductory slide also. Dosha nirmulana, dosha nirharana, pitta dosha removal, followed by alpa kapha nirmulan. After that, Agni Dipana, because it corrects the metabolic dysfunction also. At the same time, Sroto Shodhana, it induces the clarity of channels also, various circulatory channels also. At the same time, Dhatu Prasadana also, because it after the purification therapy, automatically the rejuvenation of the various tissues occur very well at a micro level also. And disease prevention, definitely, because Virechana is prescribed based on the preventative aspect in the Rutucharya also, because in Sharad Rutucharya, the application of Virechana is always praised. And again, the Charak, I think it is the greater contribution by Acharya Charak, that is before going for the Rasayan Chikitsa, Virechana or any Shodhan therapy, it is a very is considered as ideal for the to attain or to obtain the maximum therapeutic benefit of the Rasayana. So I think these are the major goals of therapeutic goals which we can attain through the Virechana. Now, what are the classical contraindications? I know you are all PG scholar are oriented regarding the classical indications and classical contraindications of the Virechana. So we will not spare more time for that. So I have concise here what are certain physiological and pathological contraindications for the Virechana, which we can categorize them certain physiological one, or some Varga Virodhi Janna Vyadhi, some Guda Vikara, some Manasik Bhavas, because it directly, it adversely affect the therapeutic outcome of the Virechana. In some, the patient who are, or a person who are routinely undergoing the Vatakara Vihara, or he or she are consuming Vatakara Ahara. So in that circumstances, there are quite limitation for prescribe the Virechana treatment. And other Adman, Urustamba and Rajakshma, these are again some additional contraindicated condition for the classical Virechana. Ashtanga have specifically specified some physiological contraindications also for the Virechana, like Bala, Vruddha, Hati, Krush, Stool, Durbal, that is having the less physical strength and mental strength also. But when we will go through the all contraindication, we can summarize certain points, or we can make certain conclusions that what happened, the Acharya Raka, when we will go through the contraindications of the Virechana, Acharya Charak, their perspective is, can the patient tolerate that Virechana? If it is okay, then definitely we can go for Virechana. So ultimately, what Acharya Charak emphasizes, the physiological suitability of the Virechana for that particular patient. Second one, Acharya Sushruta always emphasize that will Virechana be safe in this patient? That is, safety aspect is covered by Acharya Sushruta. So I think the clinically applicable contraindication framework is very well or exclusively narrated by the Acharya Sushruta. And what about Acharya Vagbhata? Is the patient practically fit for the Virechana today? Because they are assessing the current status of the patient. Because in what happened in certain condition or in clinical practice also, when we will go for the prior Dipan, Pachan, that is when we will ask the patient for the Purva Karma of the Virechana, patient is fit, no any contraindicated condition for that. But what happened between the duration from Dipal Pachan to the completion of the Abhantar Sehan and Sedan, what happened? There are multiple confounding factor, or there may be multiple aggravating factor which can adversely affect the physiological condition of the patient, which may restrict the patient to undergo the Virechana. So I think the daily assessment of the patient prior Virechana or during the Purva Karma of the Virechana is very, very important. So Acharya Vagbhata specifically emphasize over the success of Virechana depends as much as patient selection as on the procedure itself, because these are the equally important factor for getting the excellent therapeutic outcome. But when we are going to critically analyze all these indications and contraindications, but what happened in the current era, we have to aspect or we have to expand these classical indications on contraindications more than that, because what happened nowadays, the picture is really very frustrating because lifestyle diseases are getting more prevalent. So in order to combat such disorder, what happened, we have to deal that particular those conditions through multiple our Panchakarma modalities. So what happened, the successful Virechana depend not only just on the appropriate indications, or not just only depend upon the assessment of the Shuddhi or the purification level which we are achieving in our person, which we have undergone the Virechana therapy. But I think this successful Virechana is equally important on the meticulous identification of contraindications and the patient suitability also. So Rogi Bala and Rogi Pariksha plays a very crucial role in the effective administration of the Virechana. So I think all these fact really reinforce the need for standardization of pre-procedure screening protocol for the Virechana. Now, I am expanding certain clinical scope of our Virechanakarma from classical Pitta disorder to the systemic disease modulation, because there are the wide range, because there is the wide list for this condition also, for which we can advise the Virechana therapy. I have derived from this clinical practice various research evidence which I have obtained here, and modern disease prevalence. So I think there are this list can be the newer indication for the Virechana apart from the classical indications, because in metabolic disorder, yes, all the evidences, research evidences which depicts that the Virechana is effective in obesity, metabolic syndrome, dyslipidemia, non-alcoholic fatty liver disease, prediabetes, or early or just newly diagnosed type 2 diabetes also.
2 ಗಂಟೆ 1 ನಿಮಿಷ ಬೇಕಂತೆ.
ಬಹಳ ಹೈಟ್ ಐತೆ ಅದು, ಹತ್ತ ಕಷ್ಟ ಆಗುತ್ತೆ.
ಹತ್ಬೇಕಾ ಸರ್?
ಬೆಟ್ಟ steps
Dr. Sushma, I think some mic is on.
Yes, ma'am. I'll ask them to unmute themselves.
Yeah. So these are the metabolic disorder in which we can Virechana can very effectively offer significant therapeutic outcome for the same, because all these conditions having the predominance of Kapha, Pitta, Medadushti, Agni Manda and Srotoroda. So I think with the help of Virechana, we can deal it very well. Second condition, chronic liver and hepatobiliary disorder. Fatty liver is a very common, whether it is alcoholic or non-alcoholic. So in both conditions, we can prescribe the Virechana. Drug-induced hepatic dysfunction is a very common nowadays. Chronic hepatitis, hyperbilirubinemia, gallbladder dysfunction, maybe because these are the prime site of the Pitta. So to correct that Pitta, Virechana can play a very important role. There are the more prevalence of certain autoimmune disorders also, or inflammatory disease also. So in that condition, particularly the rheumatoid arthritis, psoriasis with arthritis, ankylosing spondylitis, autoimmune various skin disorder like pemphigus folliculitis, all having the more prevalent. So because what happened due to Virechana, when we will go through the various mode of action or pharmacodynamics of the Virechana, we can assess that, or we can see that it alter the autoimmune responses. Virechana can alter that autoimmune responses through its antioxidant action, through its anti-inflammatory action. So I think we can better deal as a main therapy for such kind of diseases. Dermatological, that is Kushtha. Kushtha, it is the chief rogadikara for the prescription of the Virechana. But apart from the classical Kushtha, there are the multiple disorder like acne vulgaris, lichen planus, vitiligo, rosacea, chickenpox. In multiple conditions, we can prescribe the Virechana. In certain endocrinal disorders, in practice, in clinical practice also, we are routinely prescribed polycystic ovarian syndrome. Specifically, patient is obese. In that condition, Virechana plays a very important role. Hypothyroidism associated with obesity and kapha predominance. Definitely, we can think for the Virechana. Menstrual disorder, but associated with some pitta kapha vitiation. In that condition, Virechana can be the better option for the Shodhana. In lifestyle diseases, we are already sedentary lifestyle is everyone syndrome or recurrent acidity and GERD-like symptoms, stress-induced digestive dysfunction. Maybe in IT field, it may be useful for the same. Chronic constipation associated with pitta and kapha. All these conditions, I think we can take as a newer indication for the Virechana. In certain type of allergic and immunological condition like food hypersensitivity condition, because here we have to focus over gut microbiota. So I think, and definitely the Virechana corrects that gut microbiota. So I think it is a major contribution of Virechana for the management or prevention of such disorder. And for rejuvenation and preventative purpose, what happened? As I told earlier, it is the really the crucial part of the seasonal detoxification therapy, and even multiple spa centers are already applying it as a important wellness packages. Anti-aging, we can add this Virechana in an anti-aging protocol also, because due to the antioxidant effect out of that particular therapy. And pre-Rasayana purification, as I already mentioned, in the therapeutic goals achieved by the Virechana. And all certain neurological conditions, multiple sclerosis, migraines, with strong pitta predominance, chronic headache, definitely we can apply this Virechana as a main treatment. In oncology supporting care, what happened in oncology or patient having certain carcinoma, in that patient, classical Virechana is definitely not recommended. By assessing risk benefit issue, we have to decide which kind of Virechana we have to prescribe. In what condition, what happened due to certain radiology and chemology medications, there are the multiple GIT disturbances, chronic constipation, hyperacidity, nausea, all symptoms are developed. So combat certain disorder, definitely, if we are not, or patient is not fit for the classical Virechana, instead of that, definitely we can go on for the Nitya Virechana or the Mrudu Virechana also. But in that sector, the Virechana offers only the supportive treatment or as an adjuvant therapy, not a pain therapy. So this can be the newer indications, I think so. So when we critically analyze these classical indications and the practical indications, we can found that the traditional focus of Virechana was completely dosha-based one. But what happens when we are correlating with this concept for the contemporary aspect, then what happened? This transition from dosha-specific condition to the system-wise therapeutic application be possible, and this situation really demands for the standardization and create the really need for the evidence-based research for the Virechana outcome. I think as like Virechana indications, we can also think about the newer contraindications of the Virechana also. So I will do two categories, that is absolute and relative. What happened in absolute? There is no Virechana should be strictly contraindicated. But what happened in case of relative contraindications? Yes, as I said earlier, in the oncology sector, what happened? By assessing the risk-benefit ratio for the particular patient, for the particular therapy, we can, as a physician, we can take the decision what we have to do, what we have to adopt, which kind of Virechana therapy, which medicine I have to apply. So we will go through the absolute contemporary contraindications of the Virechana. I think we are already aware that is severe cardiac disease, severe renal failure, severe dehydration, acute inflammatory bowel disease, flares, or gastrointestinal emergency. I think this can be considered as the absolute contraindications for the Virechana. But what happened? Because in all these conditions, if we prescribe the Virechana therapy, it may lead to fluid and electrolyte imbalance. Maybe the patient may face some certain hypovolemic shock also, or it can worsen the dehydration also, or it may exacerbate the symptoms, clinical symptoms of the comorbidities also. So in such condition, we have to avoid the Virechana. Other contraindications, advanced malignancy with cachexia, because patient strength, the physical strength of the patient doesn't support for going for pre-procedural, main procedural and post-procedural care of the Virechana. Pregnancy, again physiological condition, which is already given in the contraindicated list by our acharyas. Severe anemia, because bulk is very less. Uncontrolled diabetes, because there are more chances for getting the ketoacidosis in such patient. Specifically, we have to take care when we are planning for in a diabetic patient with there are some fluctuations in the sugar level, or if they are on the insulin injections. Even severe psychiatric disorder, acute psychosis, severe depression, agitated patient, because they are not able to comply the all protocol given as per the SOP, classical SOP of our text. As I said earlier, there are certain relative contemporary conditions also for the Virechana, that is elderly weak patient, children, severe hypertension, acute infections, post-surgery recovery. Specifically here we have to focus, that is especially after abdominal and anorectal surgery. I think we should avoid to prescribe Virechana therapy. At the same time, if patient having typhoid, then after up to the 3 to 6 months, I think it is better to avoid the Virechana therapy. Severe patient having the severe electrolyte imbalance also, specifically the hypokalemia and hyponatremia, we have to avoid the Virechana prescriptions in such kind of patient. What are the critical insight for the classical contraindications and contemporary contraindications of the Virechana? Yes, because classical contraindications are primarily focused on the Rogibala, Agnibala, physiological reserve and ability to tolerate the Shodhana. But at the same time, we have to take into consideration about this basic principle while deciding the newer contraindications also. But border contraindication additionally emphasize the organ dysfunctions, electrolyte imbalance, pregnancy and critical illnesses. Because in that condition, we have to strictly avoid the Virechana. I think this evaluation in this indication with respect to or in context of Virechana may reflects a transition from an individualized constitution-based exclusion approach to risk-stratified safety framework. Because we doesn't want or we should not deviate our classical principles of the Ayurveda. We have to strictly adhere with that. By considering the current scenario, we have to do certain modifications as per our yukti. This is the classical SOP of Virechanakarma. We are already aware because it is the Purva Karma, Pradhan Karma, Paschat Karma. These are the 3 procedural steps which is applicable for all type of Panchakarma therapy, specifically Pachan and Dipanin expected in a certain Kapha Meda predominant conditions, or in a Santarpanchana conditions, or in a certain NSAIDs or lifestyle conditions. We can definitely add the Rukshana therapy in the pre-procedural protocol of the patient. Abhyantar Sehapan, Bahya Sehapan, Swedanpan, it is a very utmost important protocol prior Virechana. Ahar Vishesh Upayoga, that is we have to rethink, we have to decide the all dietic structure during the Sehapana and before going for the Virechana. So it is very important factor, because specifically in Virechana, we have to ask the patient to strictly avoid the Kapha-Kleshkar Ahara. Pradhan Karma, as we are already, there is the specific SOP or there is the specific steps for that. And Paschat Karma also plays a very important role to offer the maximum benefits of that particular therapy. At the same time, it nullifies the side effects of the therapy, it nullifies the rate of complications also. So Sansarjan Kram, it is very important. Now, most important thing in Panchakarma, that is Purva Karma of Virechana, what happened? The Sushruta, Acharya Sushruta have exclusively mentioned that the Vamana should be incorporated as an important pre-procedural protocol for the Virechana. Because in Charak, Sushrut Chikitsa it is already mentioned. Because if we have not followed this, what happened? If there is some little bit obstructions due to kapha, and if we prescribe the Virechana in that particular patient, what happens? There are chances of kapha prakopa, which may lead to the certain complications like grahani and heaviness in the body or pravahika like symptoms. So the classical sequence of Vamana followed by Virechana reflects a strategic dosha's hierarchy. Because what happened? The kapha eliminated first to remove the obstructions, and then definitely it will be very easy to pitta and rakta shodhana very well. According to modern, the complementary effect on the metabolic regulation with the Vaman targeting on the kapha meda excess and Virechana, what happened? Due to the combined action of Vaman and Virechana, what happened? Because both Vaman and Virechan, they reduces the insulin resistance, they increases the glucose uptake by the cell, they reduce the hepatic glucose production also, and at the same time they also overcome the impaired insulin secretions also. So all these pathological processes are the important factor in the pathogenesis of various metabolic diseases. Now, second critical analysis regarding the time of administration of Virechak drug. What happened? Because there is specifically mentioned by Acharya Vagbhata, kafe gate jnatva koshtam samyak vishuddhaye. That is, the administration of Virechana Aushadhi or Virechana Yoga should be only done after the avoiding or after passage of the kapha kala. So ideally what happened? We generally plan the time of administration of the Virechan medicine or Virechak Yoga between 9 a.m. to 11 a.m. That is after passing the kapha kala. So because what happened, the classical Shodhana Virechana is generally administered after kapha kala. Whereas if you have to prescribe nitya depending on disease condition, bala of the patient, agni of the patient, we can definitely alter the time of the medicine for the nitya or mrudu Virechana. According to the practical onset, intensity, duration, completion of Shuddhi, and thereby directly affecting the therapeutic outcome of the patient. So I think the when we are going to decide the time of administration of Virechak drug, the success of Virechana depends upon not only just Virechak drug, but also an administrating at the appropriate kala where the physiological readiness of the patient is there, and dosha dominance favor the optimal Shuddhi for the patient. So these are the classical pharmacodynamics of the Virechana in what happen in this condition, because there are certain guna, that is Sukshma, Ushna, Vyavai, Vikasi, all having the Virechak drug should possess all these property, because based on the properties of Virechak drug, we can justify the pharmacodynamics of the Virechana. Because what happened due to that particular virya and specific the adho bhagahara prabhava of that Virechak medicine, the Virechana of the elimination of this morbid dosha, this action can be carried out in an easy way. Again, contributing factor for the action of Virechana is the predominance of Prithvi and Jala Mahabhut, which precedes them for the motivation of that or elimination of that vitiated dosha in a downward direction. If we have to go through the pharmacodynamic of Virechana, it can be, according to the modern science, it can be carried out at the local action and systematic action also. So in a systematic action, what happened? in local action, it induces the Virechana effect by dual effect. First one on the content of GIT, and second one on the by doing action on the mucosal wall of the GIT. Related with the content of GIT, what happens? The all Virechak drug softens, irritates, flushes out the abnormal growth of bacteria and rejuvenates the normal intestinal flora. On the other side, when they are acting on the mucosal wall of the GIT, it increases the motility by activating the mesenteric plexus and accumulation of water and electrolyte in lumen by altering the absorptive and secretory activity on the mucosal cell. At the same time, it altered mucosal permeability may respond to the acute inflammation by action of the histamine, and ultimately the secretion is enhanced by the activation of CAM in the Krebs cell, causing the intracellular signal transduction and enhancing the prostaglandin synthesis. So, hydrophilic or osmotic action of this Virechana drug may cause increasing volume of colonic content, resulting in inducing or promoting the propulsive activity of the intestine. In the systematic action of the Virechana drug, it can be carried out based on the two reflexes. The first of all, the defecation reflexes and action of the nerves and hormone. And that's why the Virechana have the action on the nerves and hormone. That's why this is the initial therapy, the various endocrinological and hormonal imbalancing or in a certain gynecological disorders also. Probable mode of action of Mrudu Virechana, because there are certain types of Virechana, Mrudu Virechana, based on the properties of Virechana, Ruksha Virechana, Snigdha Virechana. Again, we will discuss the classification according to the Sharangdhara also. So, the probable mode of action Mrudu Virechana, when we are ingesting certain laxative, that they hydrolyze in the GIT and causes irritation of the intestinal mucosa, which may modify the permeability of the cell, and it may increase the peristalsis via intestinal nerve stimulation, which may increase the fluidity and electrolyte secretions at the GIT level. So it leads to the distension of the abdomen and evacuation of the soft bulky stool and direct stimulation of ENS also. So at the same time, expulsion of toxins take place, fluid takes place, at the same time electrolyte through the anal route also. So by overviewing all these mode of action based on the classical approach and modern approach, what we have to do, as I said earlier, it is not just merely bowel evacuation, but it acts systematically through Koshta Shuddhi, rejuvenation of dhatu, restoring the Srotas patency, because by removing the obstructions of the kleda, it improves the Agni and dosha elimination. So it is not just restricted to the Pitta area, it offers the systematic effect all over the body. So, and according to the modern perspective, when we are going to connect all these steps to the modern, definitely Virechana may act through the modulation of gut-liver axis, enterohepatic circulation, gut microbiome, some action on the inflammatory mediators and metabolic pathway also. Maybe it correct the metabolic pathway. That's why these are helpful in the metabolic diseases. So thereby producing the effect far beyond the GIT. Again, Virechana so should be viewed as a systemic biopurificatory intervention rather than a simple purgative procedure, because it influences over the doshic balance. It maintains the harmony between the dosha dhatu mala. At the same time, it maintains the whole body metabolic homeostasis also. Now, when we are come to the classification, because as I said earlier, we are the multiple classification of the Virechana drugs specifically are narrated, but according to the Sharangdhara, the action, there is the certain categories given, 4 categories has been given, because the drugs in these different categories have the different intensity for the purgation, because Anulomana, Stransana, Vedana and Rechana, because in sequence, this sequence of the Virechana drug or the Virechana type of Virechana represents a gradual transition from bowel regulation to true systemic Shodhana. Because what happened as comparative to Anulomana, really Rechana is quite more strong. So according to the clinical condition, we have to decide what we have to choose. And again, I have to add certain thing, but restricted to these four classification. Same Shuddhi, it is not applicable for four types, because the potency of the drug which we are choosing for this purpose is quite different. Because Anulomana drug is quite different, Stranson drug is quite different, because there is the basic difference in their pharmacodynamics. Again, the mode of action differed markedly among the four types. Therefore, Langiki and Andiki criteria may be more clinically relevant, but may be more vary from these Anulomana, Stransana, Vedana, etc. So, I think based on the what therapeutic action we are expecting in that particular patient, we can prescribe the particular type, or we can choose the specific type of Virechana for a particular condition. For example, Anulomana, the functional bowel disorder, definitely it will get the better result. For purpose, we have to use Virechana principle for the preventative aspect or wellness, then definitely we can use the Stransana. Vedana, if there is severe constipation and cough associated with certain Kapha-Meda conditions, in that conditions we can definitely use the Vedana concept. Virechana, it is quite with the classical Shodhana, and it is quite helpful for the metabolic reset. So according to the which therapeutic action is expected, we can choose the appropriate type of Virechana for the same. Again, what happened in the clinical practice, or it is a major concern, I think, the variable, the Shuddhi which are obtaining through use of these four types of Virechana, what happened multiple times, physician is not able to differentiate between that. So that's why multiple time there occur the treatment failure also. So it's very, I think, very crucial thing if what is we are expecting. So I think in the the very much work is needed in this area of Virechana based on the again that we have to do certain critical analysis of Virechana in a multiple pathological conditions. Anulomana can be prescribed, or we are routinely prescribed. Arsha Chikitsa, Udavarta, Adman, Pandu. In Stranson, in Jwara, Gulma, Shvitra, Vatvedi, in such condition, we can advise Stranson, Vedan, Prameha, Shwas. As I said earlier, if there is some Kapha and Meda association, then certainly we have to add Vedan treatment. Or there is some worm infestation, Dara, Kushtha, Kamla. In such condition, recurrent purification therapy is advised in the form of Virechana. Now, the important part, that is after getting or after following the all SOP of Virechana, if we administer a Virechana therapy, then most important thing, we have to observe the patient or that particular person for the particular specific assessment or the type of Shuddhi. Because what happened, the classical Shuddhi assessment is generally based on the four classical tools called as Antiki, Vegiki, Maniki and Lengiki. Antiki, particularly, it is based on the end product. What is the end product of your therapeutic purgation? Vegiki, which, how many numbers of Vega? Maniki, how much quantity of the mala, how much quantity of the material is evacuated or to all process of the Virechana. Lengiki, definitely clinical signs and symptoms of the patient. So these are the basic tools, assessment tool for deciding the type of Shuddhi in Vamana as well as Virechana also. So what happened? Why Shuddhi is important? Why type of purification is important? Because when we will go for Vamana and Virechana specifically, this importance of Shuddhi is there because it determines the therapeutic percentage of therapeutic success. So we can, based on that, we can decide the duration and type of Sansarjana practices. We can decide the future prognosis for the planning of next protocol of the patient, and research validity purpose, this Shuddhi matters very well. Now, but there are certain limitations of each and every tool also, because the lack of objectivity, I think we will go in, we will see in next slide also, the lack of objective parameter, it is the basic our limitation for assessing this Shuddhi. Because what happened, Antiki having very low objectivity, Vegiki having certain moderate, because it is in counting, quantitative nature is there, so there is no issue. Maniki, again there is quantitative, so it possesses the moderate objectivity, and Lengiki having high clinical value, but need to do very critical observation of the patient. But I have to add certain thing that quantity, it is not equal to quality. So outcome matters more than the Vegas. So these are certain controversies or contradictory points also. So we will see one by one. In Antiki Shuddhi, what happens? The assessment is based on what is the terminal elimination. The kapha, expulsion of kapha is expected as an end point or the terminal point for the Virechana. What will be the kram or what will be the order? First one, Purisha, followed by Pitta, followed by Kapha should be there. Terminal Kapha appearance or it depicts that this is the endpoint, complete purification therapy. So Kaphanta is the objective criteria for the endpoint that indicates Koshtha or Pitta is completely eliminated. After that, Kapha is getting evacuated. In Vegiki, what happened? As I said earlier, it is a number of count. What are the urges? Sorry, what are the purgations? How many times? What are the number of bouts are there? The assessment through number of bouts are decides the limitations towards Vega. If patient having 30 Vegas, then we have to stop the, to avoid certain Ati Yoga condition, we can stop the patient. So, in Vegiki condition, what happened? According to Pravar Madhyamavar, 30, 20, 10 Vegas are given respectively in our classical text. In Maniki, as I said earlier, it measures the quantity of the expelled matter. So, assessment by quantity expelled. Limitation towards the elimination of associated fluid. It is not just only limited to Purish, because it evacuates dosha also. So, what happened? The fluid components, the quantity of fluid components which is getting evacuated, it should be measured. So generally what happened? 4 prastha, 3 prastha and 2 prastha. These are the ideal quantity which are narrated by our Acharya for the Pravar, Madhyam and our Shuddhi respectively. In Laingiki Shuddhi, because it is have more clinical importance. Assessment through generally the clinical manifestations just opposite to the Amalakshana, and it is a very important method for the assessment purpose for the therapeutic outcome of the Virechana. And it is appear only when Ama is eliminated from the Sharira or toxins are removed from the Sharira. So all the Lakshana should be mentioned by the different Acharya, but all Lakshana, it is not mandatory that every symptom should be observed in each and every patient who are undergoing for the Virechana therapy. Along with that, there are the specific symptoms which are narrated by our Acharya as a Laingiki Shuddhi, Samyak Lakshana, Ayog Lakshana, Atiyog Lakshana. There is some the set of symptoms. So for Sroto Shuddhi, Indriya Prasadan, Laguta, Agniruddhi. Now, overviewing all these Ayog Lakshana, Samyak Lakshana, Atiyog Lakshana, I think these are quite challenging to assess each and every symptom. And to induce the objectivity in each and every symptom is very, very difficult task. So that's why we have to do the certain gradations based on the scientific ground. At the same time, if we are applying to able, or if we are to apply certain modern criteria for making the assessment of the particular symptom, it may become the better option. We will go through that also. A second one, if there is some like Laghuta. Laghuta in what context can we, how we can measure it is again a questionable mark. So I think such type of scales, standardized scales, questionnaires, or certain types of gradations, I think we can develop for the same. Again, in Laingiki symptoms, what happened? That is observations of Ayoga and Atiyoga Lakshana. What happened? Because in Laingiki symptom, if Sayog or a Samyak Yoga of Virechana not obtained, in that cases, what we have to do? We have to assess the patient for Ayoga or Atiyoga also. We have to cross check, and by identifying the symptoms of Ayoga and Atiyoga as early as possible, and to adopt the certain management or treatment measure to deal with that symptoms. So in Ayoga and Atiyoga, that Acharya Charak has given again 10 Vyapad, and Acharya Sushruth has given 15 Vyapad for the same. So all these symptoms which are comes under the category of Atiyoga and Ayoga, we have to keep into mind. Now, though these 4 classical basic tools of assessment are provided by our Acharya for making the assessment of the classical Shuddhi, but there are certain limitations, certain not particular type of that tool is fulfilled with 360-degree angle. So each having the certain pros and cons also. So in first Antiki Shuddhi, actually these are considered as the end point of the therapy. It is classical and authentic. But what happened? But it at the same time it reflects the dosha utklesha also and expulsion sequence also, which is very important. But there is certain limitations for the Antiki Shuddhi because it is the subjective interpretations of the Kaphanta and Prittanta, or may not happen or in every patient also. So what happened multiple times, patient achieves the therapeutic outcome or the complete Shuddhi of the patient, Shuddhi of Virechana. But this Kaphanta symptoms doesn't occur. So there are certain challenges also. Due to these limitations, there is certain challenges, that is differentiating Shuddhi or elimination of the particular material we differentiate from the intestinal mucosa also. There is another challenge is inter-observer variability also. If we are the single person doing the assessment of the same patient, then it is okay. But 2 persons are assessing for the same patient, that it is quite difficult, and they may face the challenge for this inter-observer variability. So possible solutions, standardized visual criteria and photograph atlas can be developed for this Antiki Shuddhi standardization. Training of observer can be, we can provide to reduce the inter-observer variability. And we can correlate this Antiki Shuddhi with the other Shuddhi parameters of given in the classics. Again, next, Vaigiki Shuddhi, number of Vegas, early measurable because these are countable, quantitative parameter as in classics, useful for grading as a Pravar, Madhyam and Avara Shuddhi. But what is the limitation? Number of Vegas alone does not indicate the quality of purification, because in further slide we will go through the research which has been carried out over the different cases of Virechana. So all this evidence suggests that the number of Vegas alone does not indicate the quantity of purification. So it is very major limitation of this type of Shuddhi. I think again the Vaigiki Shuddhi is again influenced by the age of the person, Agni of the person, bowel nature or koshtha of the patient, bowel habits, and medicinal potency also. So there are certain variability in such practices. So accurate counting of Vega during the prolonged procedure, it is quite challenging in clinical practice. And to tackle this challenge, what we can do, the use along with the Antiki and Maniki assessment, if we are doing with Vaigiki, then it is quite easily, it is quite authentic. So we can maintain this standardized Virechana observation set. So there is strictly adherence or observation for this sheet, it can contribute for the proper assessment. Again, Laingiki Shuddhi, as I said earlier, they depict the clinical signs and symptoms. So A basic advantage, it reflects the patient-centered outcome in the form of different signs and symptoms. It indicates the physiological and subjective improvement also. But what is the limitation? Highly subjective. It may be depend upon the patient to patient, and difficult to and compare between the patient having the same clinical condition. So it is quite challenging. So variation in the patient perception and reporting. This is very challenging task in case of Laingiki Shuddhi for both women and Virechana. Possible solutions, structured system scoring. If we have developed, as I said earlier, if we have developed certain structured symptom scoring scale which can be acceptable at the global level, which can be useful for the proper assessment based on the Laingik Shuddhi. We can use the validated Likert form or VAS-based assessment tool also. Maniki Shuddhi, measurement of stool output. These are quietly objective and measurable. Really, it is useful for the research, and it can be useful for research and standardization also, and less observable bias. Limitations, collection and measurement. Cumbersome can be the major limitation for the same, and quantity does not reflect the quantity of Shuddhi, as I said earlier. So, again, challenges, complete collection of stool output in OPD and IPD setting. Measuring mixed to liquid content accurately. These are the basic challenges in the Maniki Shuddhi assessment. So possible solutions, what will be the possible solutions for that? Standardized collection container for the stool, digital weighing methods, calculate net output after deducting intake as suggested by the Morton research. These are maybe the possible solution to make standardize the Maniki Shuddhi. Now, among these 4 type of Shuddhi or 4 assessment tool, Laingiki Shuddhi is always praised by all our Acharya because these are superior. Why these are superior? Because what happened in Virechana, there is not just only elimination of the Vikruta Pitta, but at the same time, Shariragata Kleda in the different form of fluids or liquids is also eliminated. So, the specificity of Virechana is even eliminating the maximum fluid. There is no signs of dehydration at all. I think this is the very prime uniqueness of our Virechana classical therapy. So, Laingiki Shuddhi, what it compromises? It compromises the functional outcome. It compromises the physical response of the body given to the medicine and procedure and clinical efficacy. We can integratively combine all these basic and definitely it can lead to the Laingiki Shuddhi. Now, if we have to do the critical analysis of the different opinions given by different Acharya for this Shuddhi level or assessment of the Virechana level, the Charak approach, what Charak emphasizes that they are completely focusing on the dosha elimination, clinical outcome, and Shuddhi grading, Pravar, Madhyam, Avar. What Sushruta procedural excellence, that is how much and up to how much percentage we are getting strictly adhere with the SOP. So it is very important. And again, safety point of view, it is a very major contribution of the Sushruta, which is depicted in the Laingiki symptom or Lakshana, that is Ayog, Atiyog, and Samyak Yoga of the Virechana given by the Acharya Sushruta. What according to the Vagbhata perspective, they have integrated based on doshas, vegas, and clinical science, and all 3 are depicting in the classical shlokas given in the Samyak, Ayog, and Ati Yoga of the Virechana by the Acharya Vagbhat. Again, the Charak and Vagbhata have strongly emphasized or more emphasized over the dosha elimination, and they both have emphasized over the clinical sign symptoms also. But Vagbhata, along with that, they are specifically recommended for the number of vegas also. So now again question remains, which Shuddhi is more important, whether number of vegas, quantity, or symptoms relief? What is important? So I think research evidences can give the better answer for to to solve to gain the get the answer of this question, because there are certain research which has so I have tabulated here certain authors who had conducted all this study. That is, some studies reflect that weight count alone inadequate. One study reflect that Antiki criteria is very important. Barik et al. Author 2019 study report that large variability in the Shuddhi outcome. And again, further research study which is latest published in 2026, Tikshna Virechana, it is not means that Pravar Shuddhi has been attained by the patient. So again, variability in the current clinical practice of Virechana has been exclusively depicted by study Barik et al. In 2019. Safety of Samyak Virechana over the serum electrolyte has been carried out by in 2013. Again, there are the different biomarker studies of all carried out. Now, there are the some studies carried out based on the standardization of Vaigiki Shuddhi also, because and they are depicting, that is, the Vega number or count is not sufficient to depict the type of Shuddhi, because it is not just for the type of Shuddhi. Because what happened, there is a study which has been carried out, that is for Virechana purpose, Danta, that Danti Avaleha has been used. That what happened, there occur Krura Koshta patient has obtained the Pravara Shuddhi. Madhya Shuddhi patient have obtained our Shuddhi in spite of giving the repeated doses of the Virechak medicine. And all patients show Shuddhi, which is a type of Antiki Shuddhi. This proves that same Vega means it is not equal to the same Shuddhi. Koshta may affects the definitely outcome of the Virechana, and Antiki Lakshana may be more reliable than the Vega count. These are I have these are the some PubMed studies which are mentioned here. So, and certain limitations of Vaigiki Shuddhi has been also documented by this Changanti et al. And Mulkhedkar 2026 study. So, by assessing all these available literature on the various databases, we can do certain 5 critical insight. First one, Virechana is more than purgation. Shuddhi assessment is multidimensional. Lengiki assessment has the greater clinical relevance, and standardization is the need of future of Virechana due to high incidences of NCD, because current Virechana practices having lack of uniformity. Yes, I know there are the multiple factors which are responsible for this variability in the Virechana practices, but we have to rethink upon it. Same, because what happened, the different percentage of the efficacy rate in different region in patient with the same disease and baseline parameters has been obtained. So we have to find out this confounding factor which are affecting the procedural outcome of the Virechana of the procedure and achieving the maximum efficacy. Standardization of this procedure assessment should be done on the emergent level. High standardization is again needed. Classical criteria really descriptive, but really it is operational. It is really question mark. I think to make it more operational, we have to take more efforts to convert them into the objectivity. Because as I said, Laguta, that is how we can assess Laguta, how much, how measured, which scale of measurement should be used for assessing Laguta as a Samyak Yoga of Virechana. So this is again really challenging for me. I think this is challenging for other practitioners also. Vega count alone is inadequate. Vega count not uniformly predictive of Shuddhi. Patient with fewer Vega may achieve Samyak Shuddhi. Patient with higher Vega may show our Shuddhi. Tikshna Virechana not equal to our Shuddhi, because these are the findings of this research which has been carried out till date. Again, next critical, that is again, why there is the need? Underutilization of the classical parameter. The clinical practice often emphasizes over the Vegiki assessment, but Antiki and Lengiki parameter are frequently underreported despite their importance. Again, high inter-individual variability, it is again main important thing which create the need of standardization, because what happens? Significant inter-individual variability maybe depend upon the koshtha, maybe depend upon the prakriti, maybe depend upon the agni. As same Virechana drug produces different Shuddhi outcome in Mrudu, Madhya and Krur koshtha. Next point for creating the need for standardization, wide variation in the clinical practice. Differences exist in the Snehapan dose, Snehapan medicine, Virechana drug selection, duration of therapy, assessment criteria, and interpretation of Shuddhi grades, which are adopted by the different Panchakarma physicians or practitioner. Okay. Again, fixed dose does not ensure the uniform Shuddhi in all patients. It is again the key findings of the research. Lack of objective documentation and objective biomarker. So no universally accepted recording format is there. So we are facing problem for the standardization. Limited use of biochemical, metabolic, microbe or quality of life markers. So again, it is quite challenging for us. Now my critical question arises. Yes, we are already aware about the 4 assessment tool of the Shuddhi. But what happened in the clinical practice? What we are facing? A patient possesses 18 Vegas but feels incomplete. Another patient passes 10 Vegas during Virechana but gets complete symptom relief. But what is the question? Who achieved the Samyak Shuddhi? And yes, and we get possible based on the standardization. But prior standardization, we have to rethink on the various challenges which are facing in current days in standardization or assessment of Virechana. What are those challenges? First one, Sneha dosage duration, different Vega calculation method, that is no universal Vega criteria is there, different assessment method with observer dependence, which leads to some subjectivity, different purge doses, no fixed dose of standardization, lack of objective assessment or biomarker, variable protocols, and different endpoints are set by the practitioner. So all these challenges leads to the poor reproducibility, difficult comparison, and so we can't end the multicentric trial with the same intervention. At the same time, there are due to this all these factors that there are the multiple in the publication process also. There are certain, but whether yes, there is the need of standardization, there is the standardization gap, and there are certain challenges also. But true success of Virechana, it is not just only the number of stool pass, but restoration of the physical harmony, improvement of the Agni, dosha balance, measurable clinical outcome. These we are all expecting as a Virechana outcome. So I think considering all this scenario based on the existing research and limitations of the classical tools, it demands the integrated Vegiki, Antiki, Lengiki assessment model based on the standardized Shuddhi Lakshana, assessment methodology, prescribing patterns, and procedural outcomes. It is already documented by these authors. So I think to correct or to face these challenges or to making some standardization, we can take certain initiative. I think certain 3-dimensional standardization model we can apply. For example, in classical domain, Vegiki, Maniki, Antiki are there, definitely. Functional domain, we can assess the patient for appetite, for digestion, bowel pattern, subjective feeling of laghava or other symptoms, quality of life, and Agni. In objective domain, we can use the multiple parameters to document the effect of or efficacy of Virechana over these parameters. Which parameters are, though we can include this objective domain, because body weight and BMI, lipid profile, blood glucose, autonomic function HRV, gut microbiome marker, safety biomarker, hydration marker, stool characteristic, its macro and micro analysis we can do, disease specific scores or disease specific standardized scale we can use for the assessment, certain inflammatory markers like CRP we can use, ESR we can use, cytokines productions or cytokines levels we can use. We can go for the hormonal assay, liver function markers, and metabolics. We can go or we can use this objective domain. So these are certain this is the specific three-dimensional model I think we can use for the standardization. Now, what again we can do for standardization? We can plan certain multicentric RCTs where the patient selection should be based on the common clinical condition, Prakriti, Agni, Koshtha, Bala, Dosha Bala, Vyadhi Bala. So it is quite important factor. Uniformity should be maintained in the Purva Karma for all type of patient or all type of population which we are using for this RCT. We can define the Samyak criteria objectively. We can develop standardized Shuddhi scale instead of the Shuddhi grading or precise Vega definition. Drug selection as per the type of Virechana, it should be common. Digital Virechana recording may help for the documentation purpose and inducing the preciseness. Biomarker correlation, it is very helpful. The different biomarkers which I have already showed in the last slide, we can add as an objective parameter. Microbiotic assessment which can help a lot, and AI supported Shuddhi prediction models or composite indices we can develop for making the proper assessment of the patient after Virechana. So this AI generated something composite Shuddhi index. I think it can include clinical score, 40% weightage should be there for that purpose, clinical score, in which all clinical symptoms which are mentioned in the Samyak Yoga, all the clinical, the depiction of the all symptoms should be there, specifically Laghuta, Agni, appetite and symptom relief should be meticulously. At the same time, for this composite Shuddhi index, 20% weightage can be given for Vegiki score, 20% for Maniki score, 20% for Antiki score. So ultimately, this composite Shuddhi index can be developed, and based on that, and at the same time, three-dimensional model, we can do the assessment for the symptom. Again, we can induce the objectivity for the clinical score in the various clinical symptoms given in Samyak Yog, Ayog and Atiyog of the Virechana, which we can be very helpful for the standardization of the process. For example, Laghuta, maybe we can assess through weight reduction, BMI reduction. Agni Dipti, we can assess through improvement in metabolic parameter or metabolic marker. Kafantiki, we can consider it as an observable endpoint. Vaigiki, Vega count should be there. Mana Prasadana, quality of life score. Dosha Nirharana, gut microbiota modulation can be done. Shuddhi, biomarker improvement can be used for the same. So there are these are the different parameters which can use as a objective parameter for the subjective one. Now there is the Virechana thermodynamics which can be correlated with the modern scientific validation based on the researches. I think it is also helpful for making the proper standardization in terms of the contemporary parameter, because what happened, according to the modern science, this therapeutic procedure, Ayurvedic therapeutic procedure, possibly influence and symptom reduction, improved metabolic parameter, because it induces the metabolic reprogramming, because it reset the metabolic dysfunction. It improves the metabolism. It improves it enhances the quality of life of the patient. It induces the systematic detoxification effect. It alters the gut microbiota, gut flora. It enhances the heterohepatic circulation, and it reduces the inflammatory mediators. So, but all to prove all this, we have to set, or we have to establish certain hypothesis, or based on that certain research study have to plan for the same. The Virechana, the efficacy of Virechana depicting its effect on the gut microbe, because it is already proved by certain studies. The clinical study, which is proved by Chaturvedi et al. What are the findings of this study? Because gut microbiome can be used as a major objective criteria for assessment purpose. What this study shows that it induces the weight reduction. Virechana induces weight reduction, BMI reduction, reduction in E. coli colonization, and correction of dysbiosis. At the same time, gut microbiota modulation after Virechana, decrease in E. coli colonization, decrease weight BMI, improved metabolic parameter. So classical concept of dosha nirharana, we can correlate it very well with the gut microbiome reset. So recent reviews after 2024 are also emphasizing that is emerging mechanistic evidence of Virechana, because what it depicts, it decreases the dysbiosis, it decreases the E. coli decolonization, increase the gut ecosystem balance, it maintains the flora of healthy bacteria, and it increases the metabolic regulation also. So it summarizes the emerging microbiome evidence. So I think they can very well connect, or we can connect Virechana with the dysbiosis correction. So these are again another studies which are putting the effect of or efficacy of Virechana over the microbiota as well as the biomarker driven standardization. The efficacy of Virechana, which defect the metabolic reset or metabolic reprogramming. So these are some, I found 3 PubMed studies which depict that the after Virechana or Virechana treatment, classical Virechana treatment, reduce the blood glucose, reduce triglyceride, reduce fatty changes in the liver, improved insulin sensitivity. So I think HOMA-B as like objective criteria we can use to assess the effect of Virechana also. So implication, that is the classical concept or classical Virechana as a Medohara or Kledhara, which can very well correlate with the metabolic reset, which are proved by this study. Again, the dual effect of Virechana, that is improving the gut microbiota as well as the metabolic reset. There are again these studies registered on the CTRI. It is the ongoing study. So it is evaluating HRV, gut microbiota, metabolic marker. It represents the future direction of objective biomarker based assessment for the Virechana. So I think it can be better study for deciding the standardization. Some studies has been carried out to study the safety validation, because for the standardization of any procedure, this important criteria is there, that is safety validation of the procedure. So effect of Virechana on the serum electrolyte study, electrolyte after Virechana, electrolyte changed slightly but remained within normal range, that is within physiological range. So no major adverse effects have been found. So it ultimately proves that Virechana is safe. So Samyak Virechana is physiologically safe when performed according to the classical standards only. There are certain evidence or certain studies which are depicting the variability in the current Virechana practices, which is the major challenges in the standardization process, because prescribing patterns of Virechanakarma in terms of Shuddhi Lakshana. This is the article of 2019. And there are certain key findings of this lecture, of this studies, that the study demonstrates different koshta required, different sneha matra, different vega count occurred in different koshta. Trivritta leha was most frequently prescribed. Physicians follow variable protocols. So in this study, total 300 patients have been recruited and evaluated our Madhyam and Pravar Shuddhi distribution and demonstrated the variability in the physician prescribing patterns. Now, again, one study which is conducted on a 26 patient of the psoriasis, which depicts the importance of assessment of Antiki criteria of Virechana, and it makes the bridge between relation of Antiki with the Antiki Shuddhi with the therapeutic response. So, Antiki Lakshana should be viewed merely as an endpoint marker of Virechana. They may have the prognostic importance regarding the treatment success. But one of the very few studies have focused specifically on the Antiki Lakshana. So, highly relevant to our theme. Again, Danti Avaleha retrospective analysis. This is the another study which depict in this study that same medicine Danti Avaleha has been used for the Virechana purpose, but in a patient having different koshta, different dose tolerance, different Shuddhi outcome. Kapantiki Lakshana has been achieved in all patients. Direct evidence again relying only on the Vega count, and Vega count alone is not adequate for assessing the Samyak Shuddhi. It is clearly documented by this study. So, Antiki Lakshana may have the greater standardization value according to this study. Tikshna Virechana, there are certain novel observations which are achieved by this. Actually, this is the case study which is carried out in 2026. Authors clearly mention Tikshna Virechana and Pravar Shuddhi are not synonyms. So, important point is that less weight, greater total expulsion, different intensity, very recent publication hai, but it challenges the misconception more Vega, that means better Shuddhi. So, I think we can distinguish Tikshna Virechana from the Pravar Shuddhi based on this article or study. So, there are another critical insights which I have done regarding the clinical utility of Virechana. The research study which has been published till date. The Virechana has been studied. The effect of Virechana have been studied by the different author across the India as well as out of the India also. The Virechana has been successfully prescribed for various metabolic, dermatological, respiratory, reproductive, gastrointestinal, autoimmune, psychological, and musculoskeletal, and significant therapeutic outcome was obtained. So, in this major 8 clinical domain, the Virechana offers the therapeutic benefits. So, it really indicates its systematic therapeutic effect. And the research study has been carried out till date. These various Virechana yogas has been used in the different studies or different clinical condition for the Virechana purpose, mostly in disease specific condition. Trivritta Avaleha, Quat, Trivrittadi Quat, Harityadi Yoga, Danti Avaleha, Classical Virechan Protocol, Avipattikar Churna, Haritki, and Goarka. These are already used by this different study in this 8 domain. Now, again, I have found one article which support that is the which denotes the importance of Shodhan therapy, prior Shamana Chikitsa. So, Virechan plus Shaman is more than Shaman alone. So, proper Shuddhi potentiates the subsequent therapy. So, in one study which is carried out on the Tamak Shwas, here occur better than Shaman alone. So, the role of Virechana in Tamak Shwas, psoriasis, Madhumeha, and Vicharchika and oligospermia, it is proved that if we are adding the Virechana along with Shamana, then it is really more efficacious than the Shaman alone. At the same time, in Madhumeha, it can be, we can say that based on this research finding, the Madhumehi patient undergoing for the Virechana purpose, they achieved better glycemic control. And in case of Vicharchika, what happened? The recurrence rate is comparatively lower in a patient undergoing for the Shaman Chikitsa only. And in oligospermia, what happened? It enhanced the Vajikarna effect also. So, the critical insights derived from all these research study. First one, it corrects the 2 correct myth. First one, more Vega is equal to better Shuddhi. No, reality is what? According to the recent observation, Vega count plus quantity explained plus content explained plus Antiki science must be assessed together. What is myth 2? All these findings correct the myth 2 also, that is Swayam dose means Swayam Shuddhi. No. Reality is what? Danti Avleya study showed that Krura Koshta tolerated 10 gram, produced Pravar Madhyam Shuddhi, whereas Madhyam Koshta poorly tolerated even 5 gram, but predominantly produced our Shuddhi. So Koshta is the stronger determinant of Shuddhi than dose itself. Again, another critical insight which I have obtained from this study, different Virechana yogas can produce Samyak Shuddhi, Trivritta Avleha, Trivritta Kwatha, Danti Avleha, Haritkadi Yoga, Avipattikar Churna, Haritki plus Goarka. Samyak Shuddhi depends more upon the patient selection, Koshtha assessment and procedural execution than upon the single ideal Virechak yoga. That's why in our classical text, according to the disease conditions, the multiple Virechak yogas have been described. Again, fourth one, Kaphantiki remains the most consistent endpoint despite variation in drug, dose, disease, and Vega count. So many studies ultimately considered successful completion based on the classical endpoint rather than the Vega count alone, particularly demonstrated in Danti Avleha study. So there is certain relationship between the Virechak Yoga, Koshta and Shuddhi, which I have found in this study also. Danti Avleha, they are the dose I have mentioned here, and the Koshta. So according to that, the Shuddhi pattern are getting varied depending upon that particular drug. So this is the research trend or the Virechana practices getting evaluated based on the earlier research was completely focused on the drug efficacy and disease outcome. What current research depicts that it is Koshta-based response, Shuddhi assessment importance, and safety markers should be properly evaluated during this study. And what future research demand? That is the Virechana efficacy should be studied based on the biomarker guided Shuddhi, gut microbiome analysis, and standardized Shuddhi index based on the 3-dimensional model. So, key practical messages from this research: in the current era, Virechana is increasingly indicated for metabolic syndrome, obesity, and 8 domains which I have told earlier. Modern contraindications additionally include severe cardiac diseases, certain emergencies having the electrolyte imbalance. So current evidence suggests that the success of Virechana is determined not by the Virechak yoga alone, but by the dynamic interactions between Koshtha, dose selection, procedural execution, and a multi-dimensional Shuddhi assessment. So Virechana is more than purgation. Always assess ama before purgation. No universal Virechak yoga exists. Koshtha-specific dosing is very essential. Prior Virechana, Vega count alone cannot define Samyak Shuddhi. True assessment of Samyak Virechana should not rely solely on Vega count. Lengiki assessment has the greatest clinical relevance as already documented by Acharya Chakrapani. Antiki and Lengiki assessment should be prioritized. So, again, practical messages we can go ahead for the same. True success of Virechana, not just only the number of stool passed, but restoration of physiological harmony, improvement in Agni, dosha balance, and measurable clinical outcome. That's why Shuddhi assessment is multidimensional. So considering the various systematic therapeutic effect of Virechana in 8 clinical domains, despite the disease diversity in the clinical condition, the end point of therapy continues to be assessed primarily through the classical Shuddhi parameter. So current practices, what happen? It is the lack of uniformity itself. So it highlights the urgent need for this objective Shuddhi assessment framework development. So standardization ensure reproducibility. So apply, observe, measure, quantify, and validate. This is the basic key message for exploring the research in the Virechana. So I think future of Virechana standardization lies in integrating classical wisdom with objective clinical markers that can convert from Vega-based assessment to evidence-based Shuddhi assessment. So we can efficiently make the amalgam of classical wisdom along with the evidence-based Panchakarma or Virechana. And for that purpose, documentation is very essential. And as along with documentation, publication is very essential. These are the references which I have referred for making this presentation. So these are from my side. If there is any questions or query, we can take.
An intellectual stimulating lecture. Your comprehensive presentation of classical parameters for Shuddhi assessment, need for standardization, enriched with classical references, practical clinical insights, and your vast academic and research experience has significantly enhanced our understanding on Virechanakarma and emphasized the importance of standardizing Shuddhi assessment in clinical practice and research. We shall now proceed to the interactive question and answer session. I request all the participants to kindly post their questions in the chat box. We shall take up the questions one by one. So, ma'am, the first question is, how to assess Sneha Utklishta Sharira where
Yes. Yes, as I said earlier, in the Virechana practices, when we are documenting all, we are doing the assessment of all these Virechana assessment tool in 3-dimensional tool, we have to make into consideration for the Samyak Lakshana of Snehana also. That is, question is that if we have to plan Rukshana, okay, then we can definitely go for assessing the hydration marker. We can definitely go for the Sahanan. We can definitely go for the various Kapha Prakopa symptoms by making them certain particular gradations or the objectives tool. So based on that, we can do the assessment of the patient for the Snigdhata. Okay, if patient is Snigdhat, then definitely we can go for the Ruksha Virechana. But simultaneously, at the same time, we have to assess the Prakruti of the patient, because if there is Vata Prakruti and patient is associated with certain Kapha and Meda predominant condition, then there is quite challenging condition for the same. So the basic factor Prakriti, Agni, Koshtha, at the same time the various dietic and lifestyle pattern of the patient obtained by the or following by the patient is very important while prescribing the Ruksha Virechana therapy in a stool patient. Or for Snigdhata association, again we can decide certain marker. For example, it is already recommended Ruksha Virechana in a Kapha and Meda predominant condition. So if we have to decide certain objective pre-marker, that is what is the Sahanan, anthropometric parameters, because it depicts the Kapha Ruddhi. Lipid profile measurement we can do. At the same time, some Kapha Prakopa Lakshana mentioned by our Acharya Vagbhata specifically, I think we can decide for making the differentiate between Snigdha and Ruksha nature of that person or the disease condition. Dr. Sushma?
Yes, ma'am. Proceed to the next question.
Yes, yes.
Okay, ma'am. The next is
Maniki Shuddhi. As I said earlier, there is a major limitation. Maniki, it already mission, that is Maniki, quantity. That is, if we are planning or if we are prescribing the Virechana, practically what we have choose, we have to collect the evacuated matter. Because based on that, until and unless we can't measure that particular quantity. And again, we have to differentiate, because that's why I have taken in objective parameters stool, fluid, liquid content, etc. I have added all these parameters. So though it is ridiculous or it is practically impossible, but if we are planning certain certain settings in that Virechana room, in that commode or toilet system, so definitely it will be possible. Dr. Sushma?
Yes, ma'am. Define Natisnigdha Virechana and mention some practical yogas clinical practice.
Please, question repeat, please.
Yes, ma'am. Define Natisnigdha Virechana and some Virechana yogas used in clinical practice.
Natisnigdha Virechana. That means in the classical indications and contraindications of the Virechana, what is said that when we are planning for the Virechana, we have to assess the bala. As I said earlier, already Acharya Charak have been recommended for the what happened in Charak's Ashtonindita Adhyay. The Atisnigdha patient having maybe some kapha predominance. So that's why what happened in the circumstances, there is a heaviness in the body, that is then kapha predominant symptoms are there. So the strength of the patient is always poor, or is sometimes what happened due to laziness or something, some kind of that particular lakshana of that prakruti, or a patient also that doesn't comply in the protocol or the SOP or the dietetic restrictions or lifestyle modifications which are prescribing for the patient. So in that situation, it is quite challenging for us. So I will recommend, first of all, we have to prescribe first Rukshana. Rukshana means for that purpose, you can, before going for the classical Virechana in this patient, we have to add along with Dipan Pachana, first Rukshana. For that Rukshana purpose, we can add some yawa, kol, kulatha, some millet preparations, some takrapans, gomutra haritaki, some Udvartang line treatment. So we can advise Bahya and Abhyantar Rukshana therapy along with Dipan Pachana. And after attaining the symptoms of proper Dipan Pachan and Rukshan therapy, then we can go ahead for the proper Abhyantar Snehapana followed by the Bahya and Abhyantar, Svedana also. And then we can go for the Virechana. In such patient, we can prescribe Virechana. Though it is Snigdha patient, we have to first taken into the Koshtha, because Koshtha is a very important factor while deciding the type of Virechana as well as the type of drug which we are using. Multimes what happen in Snigdha patient, there is the association of kapha, so there is more chances for getting Madhyama Koshtha. So in that circumstances, we have to taken into precaution for the same. But in an alternative, we can advise some Ruksha drug like Kutki. We can advise for the patient. Okay, for the Snigdha patient, for the Atisnigdha patient. So Ruksha Dravya having the Virechak property, we can prescribe for the same. If patient having the Krur Koshtha, in that situation, we can advise the Ichabediras also. Even Triphala Kalpa also, because Triphala is excellent Virechan. We can add Triphala Koth also for in such patient for the Virechana purpose.
Thank you, ma'am. Next question is, how does the mechanism of action differ between Ruksha and Snigdha Virechana? Explain with suitable clinical implications.
I think Ruksha and Snigdha Virechana I already disclosed about the same. What happened in the Ruksha Virechana? In my slide, I have already mentioned that is the Virechak medicine acts based on the local and systemic action. In local action, it acts based on the two. First one, by altering the content in the gut, and second one by altering or irritating the gastric mucosa. The same principle is applicable for the Snigdha and Ruksha Virechana. What happened in Ruksha Virechana? There will the already drug having the Ruksha properties, so it has having the greater property to absorb the excess kleda. So I think rather that is we have to focus over the local effect of Virechak medicine on the gastric mucosa or the GI tract, because in this situation we have to do two things. First one, the gastric content or the content which is loaded in the gastrointestinal tract. First we have to absorb that kleda due to the Ruksha guna of the Virechak medicine. At the same time, in the Snigdha Virechana, what happened? We have to add certain Snigdha medicine which can lubricate that content which is already dislodged in that particular GIT for Snigdha Virechana purpose. Okay, so that is the addition of Snigdha Virechana. What will happen? There is the proper propulsion of that dislodged material or stagnated material may be very possible due to Snigdha and Saraguna of that Virechak medicine. So I think this is the basic difference in the pharmacodynamics of Ruksha Virechana and Snigdha Virechana.
Thank you, ma'am. Our next question is, define Tikshna Virechana. Does Tikshnata depend on the number of Vegas or the amount of dosha expelled?
No. Actually, what happened, as I said earlier, it is not limited just only we doesn't want to restrict any kind of assessment, because based on the research ground I have already told that not a single assessment tool is sufficient to predict the therapeutic outcome. So the we have to consider quantity also, quality also, as well as endpoint of the therapy, Antiki Shuddhi also, and Lengiki Shuddhi also. That's why I'm asking. We have to use all four basic Shuddhi. We can't differentiate based on only on the, or we can't rely on the single type of Shuddhi. All Shuddhi have been equally important.
Thank you, ma'am. And our next question is, Acharya Sharangara has described a Chaturvida Virechana. In your clinical practice, for which cases do you use each type? And additionally, if you use substitute drugs in place of the classical Virechana Dravyas mentioned by Sharangara, what are those drugs and what is the rationality behind selecting them? Can the Chaturvida Virechana differentiated into Snigdha and Ruksha Virechana? If so, on what basis?
Yes, actually, Acharya Sharangara, Anuloman, Stransan, Bhedan, Rechan. Rechan comes under the category of classical Virechana. Okay, Anulomana. I think what is the mode of action of each drug, as that is which action we are expecting. For example, Anulomana. Anulomana specific expected as per the Vata Vyadhi Chikitsa. That is Vata Vyadhi treatment principle. Anulomana, we have to Mrudu Rechana. We have to use this Anulomana. What we have to do? We have to do the Anulomana of the Vata which it get obstructed. Here two things are there. First one, high Vata is obstructed. That is due to some obstruction of Kapha. Then definitely Kapha is there. Then we have to add some particular drug, that is some Sneha, but which is combined with Ruksha Dravya. Okay, so this combination will be better to get Anulomana in that particular condition. Okay, first one. Stransan means that is it having the strong potency to break that particular particular stagnated morbid dosha. In Stransana, what happens if there is some not just chronic condition, for example, in certain allergic condition, what happens? Certain that is mast cell. The mast cell secretes some histamines. So in a autoimmune diseases or certain allergic disorder, what happen after getting exposure to certain aggravating factor, histamine get released and the mucus formation get increased. So stringent drug having the more potency to get penetrate at the micro level. So I think here that is maricha. Maricha is excellent for the stringent. So the such type of drug is expected in this condition. Stringent. Anuloma Bhedan. Bhedan means in condition of generally what happen in a chronic constipation, severe chronic constipation, ficolit, or some patient which are appealing to us with that they having the they having the regular bowel evacuation, but and in comparison bowel evacuation or satisfactory evacuation has been carried out. So in that situation, first we have to break that ficolit or the stagnated mala. So here that is kutki. The kutki, it is the best for the ficolit because it has the Bhedan property. And Rechan, it is completely devoted for the concept of the classical Virechana. So in that way, we can differentiate and we can, based on the property which are expecting, we can use the particular drug for the same. Already the examples of drug is already mentioned by our Acharya for inducing that particular type of Virechana.
Thank you, ma'am. Next question. If patient had 3 episodes of Shuddhi and 25 Virechana Vega, patient was stable, parameters were within normal range, as Shuddhi is mentioned under Ayoga Lakshana, in this case, what can we conclude about?
No. What happened? Generally, what if Shuddhi occur in the initial stage of Virechana? What happened in the clinical practice when we are prescribing the Virechana Yoga between that particular Shleshma Kale Gate 9 to 11? What happened? There is some time, it may require some time to induce or to start the Virechana. What happened in the clinical practice after 1.5 hours? Generally, the purgation or the purgation bouts or Virechana week starts. Okay. So if Shuddhi is occurring between in the initial 1.5 hours, okay, because it may occur due to that particular smell of that drug, it may occur due to the irritation of that Ushna Tikshna property of that particular drug. So due to there are the multiple factors for or inducing Shuddhi in the initial 1.5 hours of the patient, because it may be due to the local action of that Virechak drug, not just and it never depicts the total outcome of the therapy. But after 1.5 hours or 2 hours, if there is no bouts of Shuddhi and there is the smooth induction of the Virechana Yoga and the patient attaining the Pravara Shuddhi, that is there is 25 Vegas are there, and at the same time Laingiki Shuddhi symptoms and Laghuta is there, and those symptoms which are classically text are obtaining, then I think it is there is no any specific need to get focus over that Shuddhi symptom. Yes, when it is necessary or when we have to take it seriously, if when we are prescribing patient for Virechana and through emesis, all Virechak medicine have been totally come out through the mouth, then we have to rethink on it if whether there is Utkleshala is there. That means we have to cross check or we have to explore, that is patient has taken some Kaphavardak Ahara or some Kaphavardak Vihara, etc. like that, or proper Snehapana is not there, or the direction of dosha, because what happened after Abhyantar Snehapana, based on the direction of dosha, we have to decide whether we have to go for Vamana or Virechana. So it may be our wrong decision. That is, instead of Vamana, we are planning for the Virechana. But if that's why Acharya Sushruta already mentioned that Vaman should be incorporated or employed as a mandatory pre-procedural protocol for the Virechana. If we are following this, then I think never occur such type of symptoms.
Thank you, ma'am. Next
Ha.
question. How to assess Shroto Vishuddhi Lakshana?
Sroto Vishuddhi Lakshana. Let me clear one thing, that all symptoms which are mentioned in the Samyak Yog, Ayog or Atiyog, what happened? All these symptoms are observed as the immediate and after some time. Okay. So Sroto Vishuddhi Lakshana, it is not just occur as immediately. It may occur after some time of the completion of the therapy also. Sroto Vishuddhi Lakshana, that means the Lakshana which is explained in Charak Sutrastan chapter number 16, what they are depicting, that is the proper expulsion of Mala, Mutra, Vata. At the same time, there is no, there is Indriya Prasad is there, that is all activeness of sensory organ, Anga Laguta is there, proper Agni is there, mental status of the patient is there. That is, so Vishuddhi doesn't depict, or it is not just only limited to one symptom. It completely denotes the physical and mental status or harmony of that particular patient. Or itself, the subsidence of the disease. It is again denotes the Sroto Vishuddhi Lakshana.
Thank you, ma'am. Next question. Role of different Anupana in Virechanakarma.
Yes. The role of different Anupana, actually already our Acharya stated that the Virechana medicine should be Rudya. It should be highly palatable. As one already delegate asked the one question, na, the Shuddhi is occur. What happen if Virechaka medicine having the specific smell, okay, or some irritation property? So the role of Anupana is basically to enhance the effect of that particular medicine, at the same time to of that particular yoga also. So I think Anupan plays a very important role. But normally what happen in clinical practice, the lukewarm water is the ideal Anupan for any kind of generally, except some Jaipal Kalpa, that is Icha Bedi or Ashwa Kanchuki Ras. In that situation, we generally ask the patient to consume Shita, that is cold water only. Otherwise, in rest of situation, it is better to advise some that is Koshna Jala. That is all Virechak medicine described with Koshna Jala. But in certain conditions, not just only Anupan, you can advise the Manuka as a Virechana Pag also. So the role of Anupan can be, Anupan can perform the or induce the Virechana Pag effect also.
Thank you, ma'am. Next question is, ma'am, biomarker, how can we imply in Virechana, and also the electrolyte assessment?
Already I have showed that, because in Virechana cases, what happened? It is not just only elimination of stool, na? It is elimination of morbid doshas in the form of certain fluids, electrolyte, okay, as like that. So first one, we can apply the various tool assessment, macroscopic, microscopic assessment. At the same time, microbiota assessment is very essential. Based on in stool, we have to assess all these things. In multiple times, we can do certain CRP also, because inflammatory orcos also. So based on this marker, we can assess the therapeutic effect of Virechana. Or in order to evaluate the safety of that particular procedure, we can measure the serum electrolyte or a liver profile also. But generally, what happen in most of the clinical condition, in the what happen after in a certain condition, if we are suffering with some vomiting or Shuddhi like symptoms, na, or diarrhea like symptoms, after getting 3 to 5 motions, there is a severe dehydrations obtained in the patient. Okay, but in case of Virechana, what happened? Even after passage of the 25 times, 26 times stools, there is no symptoms of the dehydration occur, because in Virechana itself, It is the physiological process which evacuate only doshas, morbid doshas, unwanted doshas. So it is the uniqueness of our therapy. And for creating that particular environment, that's why we are starting from this Abhyantar Snehan and Svedana also.
Thank you, ma'am. As we come to the that brings us to the end of question and answer session. Thank you everyone who participated by asking thoughtful questions and making today's session truly interactive. As we come to the end of this session, I'm privileged to propose the vote of thanks. On the behalf of the Department of Panchakarma, Tarnath Government Ayurvedic Medical College and Hospital, Bellary, I extend my sincere and heartfelt gratitude to our esteemed resource person, Dr. Punam Savarkar ma'am, for delivering such an enlightening and thought-provoking lecture. Ma'am, your scholarly presentation, profound knowledge, and rich clinical and research experience have provided us with valuable insights into the classical concepts of Virechana and highlighted the importance of standardization in Shuddhi assessment. The interactive discussion that followed further enriched today's learning experience. We are truly grateful to you, ma'am, for your graciously accepting our invitation and sparing your valuable time to share your expertise with all of us. Your guidance will undoubtedly inspire us in our academic and clinical journey. I express my heartfelt gratitude to our respected principal, Dr. Janki Vyasma, for her constant encouragement and unwavering sincere thanks to our respected HOD, Dr. Santosh Ladhadi sir, whose vision, motivation, and guidance made this webinar possible. My sincere appreciation goes to all our respected faculty members, the organizing committee, the technical committee, its participants for the enthusiastic participation and valuable support, which contributed to the success of today's program. With this, I once again thank you, our honored speaker, and each one of you for being a part of this academic discussion. Thank you.
Thank you, Dr. Sushma. Thank you very much, Dr. Santosh Yadali sir, for giving me such a nice opportunity to share this virtual dais with your PG scholar and faculties. All really, it was a very interactive session, and really, I feel very nice. So I can share some my thoughts on this virtual dais. So I am very, very thankful and offer my sincere gratitude for giving me this opportunity, and congratulate to whole team for continuity, and my best wishes for the continuity of this webinar in future also. Thank you once again, and thank you for the all audience and PG scholar for your patience listening. Thank you very much.
Thank you, ma'am. Thank you so much.
Hello, sir. Namaste, sir. Namaste. Thank you very much, sir.